minor, and then subscapularis. Okay, subscapularis. And just so you already know, I think we've already mentioned this before, but if something were to tear, most commonly it's your supraspinatus muscle. So like 92 to 93% of the time someone has a rotator cuff tear, it's the supraspinatus muscle. Which means that if someone comes to your office with a rotator cuff tear, or at least they think it's a rotator cuff tear, and they've been getting treatment for it, let's say for 2 or 3 months, and it hasn't resolved, someone else has sort of already done the work for you, and they've excluded the supraspinatus. Does that make sense? Because they've probably been treating the supraspinatus. It's not getting any better. So is it likely the supraspinatus in that situation? It's probably not. Are you still going to go in and evaluate it on your physical exam? Yeah, absolutely. But you're going to be a little more careful. Sometimes in an office, when someone comes in with a certain pain, people are like, oh, well, 9 times out of 10, the supraspinatus, and we're just going to treat that. They don't do the physical exam. You're going to do the physical exam, make sure it's really the supraspinatus or infraspinatus, or teres minor, or subscap, and then go in and treat that. And a lot of times you'll see results where other people kind of fell just because they didn't open their eyes to see the other stuff. Now, if we look here on top of this, we can see this bursa. See our bursa right through here? We said a bursa is a what?
Fluid sac.
It's like a sac. Fluid filled. Is it palpable? So if we wanted to find our subacromial bursa, which I believe we did last time, we go to the acromion, 45-degree angle, just slightly inferior underneath the acromion fossa, and you palpate there. You really shouldn't feel anything unless you've spent the entire weekend doing overhead painting, or putting stuff away, or doing military class, or putting dirt and things like that. You likely won't feel anything, right? But underneath this space, if this becomes inflamed, what's it going to begin to jam into? In the muscle and into the bone. So as we move and we activate the supraspinatus to move into something like abduction, and our supraspinatus is going to initiate about 0 to 30 degrees of abduction. It's the initiator of that motion. As it activates, it's going to compress or press against the bursa, and if it's inflamed, that's going to jam against this, and the patient's going to experience pain, and they're going to say, Doc, I can't pick up on it. It's stuck here. And it's typically associated with that bursitis. Now, we found that last time, right? Remember finding the subacromial bursitis, or rather the location of where it would be, and then we did what? We brought our arm up, and as you put your arm up above 90 degrees, what happened? So you're here, you're palpating, you do good deep palpation, keep your finger there, and then you move at the abduction over 90 degrees. What slides into your fingers right about 90 degrees? The muscle, the anterior deltoid. So as you move up, the anterior deltoid slides over your fingers. If the patient has subacromial bursitis, they're going to tell you what? Now it actually feels better because the muscle has sort of acted like a pillow between the bursa and your fingertips. So in this position, you would be touching the bursa. In this position, now you're touching the muscle because the muscle slid under your fingers, and the patient's going to be like, hey, Doc, that feels a lot better. Okay, and then you go back and you put them back into this position, and then you do what? Get them again. You just got to remind them why they're paying you money, right? So you make sure, really you're just confirming, no, it's really subacromial bursitis in that situation. So again, that's it there. But look here anteriorly, what else do we see? We see that there's a subcoracoid bursa. We can see that there's this bursa here up under the subscapularis. Any place where you're going to find tendons that might be closely related to the bone tissue that's just below it, you'll find a bursa because it's going to reduce inflammation and irritation on most structures. We get with the glenohumeral joint. Ball and socket, synovial, diaphragm, circumduction, flexion, abduction, external rotation, internal rotation. We give it all those. The scapula can also do what? The scapula can also do those things as well, right? We can retract our scapula, like pinch our shoulder blades together. We can protract our scapula, which is like rolling your shoulder blades together. And then we can elevate the scapula. You're going to find that there's normally 90 degrees associated with that, whereas with the glenohumeral joint, we normally would say like flexion's 180 degrees, abduction's 180 degrees, and so on. But with the scapula, you really just visually evaluate, is it moving the way it's supposed to? What's a good way to see if the scapula is moving the way it's supposed to? We can put our hands in this plane right here. It's called scaption. And then we can have our patients just bring it up overhead, just like this. Scaption is not quite like this. It's just slightly anterior obliquely, putting the arms I would encourage you to put your thumbs on the inferior angle of the scapula so you can also feel it. As it rises up, it should elevate, but the inferior angle of the scapula should also deduct. And the superior angle of the scapula will sort of go into deduction towards the body. So it's sort of a three-dimensional range of motion that's happening as we go through that. So it can be kind of hard to see sometimes everything that's happening. Instead, I would put my hands on it and have them do that as well too. Now we say with these bursa, we just talked about what they are. We need to know what they are, and then we just need to know these bursa. There's lots and lots and lots of bursa inside the body. It's the reason why sometimes people can get like an inflamed swelling somewhere, and they're like, I don't know what that is. It frequently can be a bursa that just needs some ice, or maybe just needs to recover. Ice is maybe iffy, but it just needs some time to recover. All I need you to know is where these guys are. Like subcoracoid's going to be where? It's under the coracoid process. So the name will tell you where it's at. Subdeltoid will be below the deltoid. Subscapular will be between the subscap and the neck of the scapula. Remember, the bursa themselves can have an open channel of communication between the two. And what that means for us as a clinician is that the patient may have pain maybe at the subacromial bursa, but if you go over here to where the subdeltoid bursa is, you'll also see it there. Okay? If you want to find your subdeltoid bursa, you can just roll up your sleeve and then just look at your deltoid muscle. As you move into that abduction, you'll see like a separation between the anterior deltoid and the middle deltoid head. It's right there in between the two. And so you can just follow up and palpate, so you can mark locations where you find the inflammation to make sure it resolves as you take care of this one. Yes?
So the best place to find this is always going to be through the anterior.
Yeah, it'll always between the anterior and middle deltoid is where you'll always find it. Yeah. And again, there can be this open channel of communication between those two portions of it, and you may find them both inflamed. Other things that can happen to our glenohumeral joint, we mentioned earlier, dislocation, right? If someone comes into your office with a dislocation, they're typically going to look like this. You're going to see the shoulder hanging down. They're going to be cradling their arm normally, and you'll visibly almost see the head of the humerus like drop down here, and there'll be a depression between the actual scapula and the humerus. We call that a sulcus sign. You can manually do this as well too by putting traction on someone's arm, by pulling right around the medial and lateral epicondyle and distracting down. And if you see a sulcus sign appear, it means that they have instability, but maybe not necessarily a dislocation. So if we're doing that, you'll learn how to do that in your upper extremity evaluation class, and you're distracting down and you begin to see the sulcus, would you want to continue pulling and pulling and pulling? No, because you may do what? You may dislocate your shoulder. So when you're doing those types of orthopedic evaluations, you have to be careful because you can dislocate somebody's shoulder doing those different types of tests. But again, if someone dislocates their shoulder, are they coming to your office? Probably not. Why would someone come to your office with a dislocated shoulder? Or a broken bone or something like that? Why would they come to your office for that? Maybe because over the last 7 or 8 years, you've been their family doctor. They look at you as their first go-to doctor. And they want your opinion first because they don't trust the medical establishment to take the best care of them that they can. Does that make sense? So when you build relationships with people, they will come to your office. I've had parents bring their kids in my office who had a fractured femur. I'm like, why are you here? You know what I mean? But they wanted to know what I felt first before they went somewhere else. So when you build a good relationship with patients, they will come in because they trust your opinion. The other thing too, someone else said it too, they don't want to be in the hospital all day long. You can go to a chiropractor's office and get an x-ray maybe in the next 20 or 30 minutes. If you go down to like Kennesaw, whatever, how long is that going to take you? 6 to 8 hours maybe to get that x-ray. So again, it can be a lot faster for you to do that. The other thing is maybe they just don't really know what's happened. Is it possible someone can fracture a bone, dislocate a bone, and really their pain tolerance is so high they don't even realize the severity of their injury? Absolutely. Absolutely. Definitely have that. Last 2 weeks ago, we talked about the different types of tears. This is specifically to an AC joint tear. For an AC joint tear, a type 1 typically means that some of the fibers have been torn, or there's no separation of the joint. A type 2 means that these two guys, the corticoclavicular ligaments, are still intact, but there's a tear at the AC joint. And then a type 3 tear is going to be a tear of all three of those, the AC joint, and then our corticoclavicular ligaments are torn as well too. You don't really need an x-ray to see that. You can literally just put your fingers on this part of the clavicle. One's going to be up here, one's going to be down here. Okay? If you see that, you probably would refer, you could take the x-ray if you wanted to, just to confirm and send that with them, so you don't need to. Frozen shoulder, what's frozen shoulder? We want to know that that's adhesive capsulitis. Itis means what? Inflammation, so there's inflammation of the capsule. Adhesive implies that it's not moving the way it's supposed to, so the tissue itself is fibrotic. And then we did a what test? You guys remember this? I sang for you. Pretty amazing. I see, you can't forget it. Teacher sings to you, serenades you. You remember the test forever. It's a Mazion, right? Okay, it's Mazion's test. They touch the opposite shoulder, bring it into the chest, and then try to elevate up. And they'll get here, and what won't they be able to do? Go any further. So you'll probably see them doing this on patients when they give you what you're asking for, so they'll do this. I got it. I'm good. Okay. We said adhesive capsulitis is typically a what kind of condition? How does it get better? Do you do something to it, or does it get better on its own? It's typically a self-resolving issue. It sometimes can take 12 to 18 months, and that's not really good, right? You can offer palliative care. Sometimes adjusting, believe it or not, will help palliative type stuff, but it won't necessarily speed up the recovery. Okay? There's some research that shows that the coracoid ligament, which connects this guy over to this guy, it just goes over the top here. There's been some experiments cutting that ligament, and it resolves adhesive capsulitis. Again, I don't know, having something cut open sounds pretty horrific, but at the same time, how much worse is it to not be able to lift your shoulder? So again, it's kind of like, the patient has to decide what's best for them. Elbow joint, what kind of joint is the elbow joint? It's a hinge type joint, okay? It's also a synovial, which is also a diarthroidal. We want to keep thinking like that because that's the way it's going to show up on our test. So I might ask you, like, which of the following is a diarthroidal joint? I might ask you which of the following is a synovial joint. I might say the elbow joint, which is a synovial joint, also known as a diarthroidal joint, would be classified as a blank. And then you would tell me a hinge joint. Does that make sense? So again, we want to make sure that we know all those because they're definitely going to be showing up on our national board test and our final exam. Now, technically, the elbow joint is not just going to involve the hinge joint. We're really going to see that because the humerus, the radius, and the ulna are all there, we're going to see that it has the hinge joint, which is accomplishing flexion and extension. But it's also going to have a pivot joint between the radius and the ulna. When we're in the anatomical position, my ulna is here, my radius is here, right? The ulna is on the midline, where my pinky side is, my radius is on the thumb side. As I move my hand into pronation, my radius crosses over my ulna. And that's the pivot part of that joint. Okay? So again, if I start here in the anatomical position, I'm technically here in supination. Remember we said I have a bowl of soup? I don't like it, so I pour it out. This is pronation. When you pronate your arm, this pivot joint allows the rotation of the radial head, and the bone crosses over the humerus and ends up on the opposite side. Okay? So in this position, it's actually the opposite side. Now, that can be challenging when you're studying cadavers, because to get a cadaver in a body bag, normally you don't leave them like this in the body bag, right? Because they won't fit through the hallway. So you do what? You cross their arms. And so when you see them, they're not in anatomical position. So people all the time will confuse the medial side of the arm with the lateral side of the arm. The way I like to think about it is pinky side is your ulna, the thumb side is your radius. So if you see a bone by your radius, you see a bone by your thumb, you know it's got to be your radius. Does that make sense? So even if the cadaver you're looking at, because you will see those on the anatomical table, they also will be like that. Not all of them, but a few of them will be crossed over like this. Just remember, thumb side is radius or lateral, and the pinky side is medial or ulnar side. Okay? And I know some of you guys probably have known that for like 4 or 5 years, but when you get into a test situation, guess what happens? You freak out. You put so much pressure on yourself, you freak out. You're like, So you need to keep it simple, right? So technically, we have 2 types of joint at the elbow joint, the hinge and the pivot. We said that the elbow joint is going to have some reinforcement. The lateral and the medial collateral ligaments are the ligaments that help support the joint itself. But we said when we're talking about those, we need to use things like the radial collateral ligament, or you need to say lateral collateral ligament of the elbow. Why do we need to say that? Because there's also one here at my wrist. There's also ones down here at the phalanges. There's also ones down in my knees. There's also some down in my feet. So again, we want to be specific to which tissue we're talking about. Now, The lateral collateral ligament, if I pull my arm into abduction, like if I'm pulling my arm towards my belly button, and I'm keeping the elbow right through here, that's how I tense the lateral collateral ligament, and it prevents the arm from incessantly going this way, right? The medial collateral ligament is right here. You feel that big bump on your elbow. Just inferior to it, you can put your thumb on that medial collateral ligament. As I move my arm away from the body into abduction, I'm stressing that ligament, okay? Now, if you're taking your patient into abduction in their forearm and it just keeps going and going and going, and you can start seeing the joint open up, what do you know is happening? There's been a tear, and we talked about the classifications of tear, right? The grade 1 tear means that there's some tissue damage there, but the tendon or the ligament's still intact. Does that make sense? A grade 2 tear means that it was maybe halfway torn, and the patient's going to experience what as you're doing this? Pain. Because there's still something left to tear, and if you're not careful, you'll tear it the rest of the way off. If your patient is just happy as they can be, and you're pulling this, and you can see the joint cavity completely opened up, you know it's a grade 3. Because a grade 3 tear is completely torn, there's nothing left to tear, so it's not going to hurt your patient. Does that make sense? So again, a grade 1 tear, grade 2 tear, you can take care of that in your office. If it's a grade 3 tear, it's completely torn off, you're not going to be able to take care of that in your office. Okay? So we've got our lateral ligament of the elbow, our medial collateral ligament of the elbow, and then we have the annular ligament that actually runs over the head of the humerus and helps hold that in place. So this blends together with that lateral collateral ligament when you're looking at it. They just kind of run on top of each other, but the difference is you'll see it go over the head of the radius as well too. Can you find your radial head? If you bring your arm just like this, and you put your finger kind of in that little hollow right through there, and then move your arm into pronation and supination. You feel that radial head moving underneath your fingertips? Okay, that's the location of that annular ligament. Remember, it doesn't help us to know what these things are if we can't find them on the body. Does that make sense? Because, I mean, if our physical exam is not actually touching the tissue we think it is, then we may be chasing the wrong thing or give the wrong diagnosis. So all of these are helping to reinforce the elbow joint, and then there's a joint capsule in there as well too, that's actually surrounding the joint. So we've got our joint capsule, and then over the top of it we have our medial and our lateral ligaments of the elbow. This is the annular ligament, and remember, it kind of blends together with that lateral ligament of the elbow. Here we can see inside the actual joint capsule itself. We've seen this a few times. We see the articular cartilage. We see the space in between there. It should be pretty uniform and even. And then we can see the space in through here as well too. We can see the synovial membrane, which creates that synovial fluid that we're going to find in all of the synovial joints. And then, of course, the external portion is the joint capsule itself. We okay with the elbow? So hinge joint, but there's also the pivot joint that's happening there between the radius and the ulna. You can also refer to it as just the radial ulnar joint. Okay. We looked at this positioning last 2 weeks ago, I guess. When we are in normal anatomical position, this is the position we most commonly find our patients in. If your hand or your pinky is getting really close to your body, it's getting very, there's an R in there, I don't know why, but that helps me. If it's very close to your body, the patient's in cubitus, which means this part of the arm, varus. Okay? If the pinky is far away from the arm, then it's valgus, it's moving lateral, it's got an L in it, and again, I don't know why, but that helps me. Valgus, lateral. Now, technically, what it means is that the proximal portion has moved medial, and the distal portion has moved lateral. Okay, so if you were to read a description like that, just look at the distal point and see what direction that's moving. If it moved medial, then you know that it's the cubitus varus. If it's moving lateral, then it will be very far away, the distal point. But technically, the definition of it's a little confusing, or at least I found it confusing when I came to the program. Wrist joint. The bones in our hand, where are the carpal bones in our hand? Oh, yes, sir?
I have a question.
Huh?
What kind of distinction are they making between abduction, adduction, varus, and valgus?
So it depends on which joint or which part of the joint you're talking about. So when we talk about varus and valgus, there's two parts that are involved, the proximal point of the bone and the distal point of the bone. In the cubitus valgus, the proximal portion is moving this way towards the body, and so you would technically classify that as abduction because it's getting closer to the body. The distal portion of the extremity is moving lateral, so it's technically moving away in abduction. Does that make sense? So it's considering both parts, and technically for you to have the cubitus valgus, this has to move this way, this has to move that way. And then for the varus, it just flip-flops. If you know one, you know the other one by just flip-flopping. We're going to find the carpal bones in our hand. Okay, the carpal bones in our hand are pretty easy to find, but we can use some different landmarks to identify those. Let's just pull them up real quick so we can see an image of it, and then we're going to palpate it so we can see them as well too. So if we go to our thumb side, and you do the thumbs up, you notice that these tendons pop out right through there? You got these two tendons that pop out. We'll learn what those tendons are in your growth 2 class next quarter. If you stick your finger inside that tendon, or in between those two tendons, you're in the anatomical snuff box. Okay? Anatomical snuff box is this space that's created right through here from the space between these two tendons. If you put your finger right there, you're touching your scapula. Okay? The scaphoid bone is in the proximal row of the carpal bones, which contains 4 bones. This one being the scaphoid. The scaphoid bone is our most commonly fractured bone. It typically happens in something like a Foosh injury, F-O-O-S-H, always on the outstretched hand. It's a Foosh injury. As we try to protect ourselves, we normally hit this part of the hand and fracture that bone. So again, if you do this with your thumb, give yourself a thumbs up, put your finger in there, you're going to find the scaphoid. If you come up and over this way, in between there, and you move your arm into, or excuse me, your wrist into extension, you're going to feel that the bone under your fingertip sort of disappears. So as you move this into extension, your lunate sort of disappears. So you have your finger on it, you move the wrist into extension, and now that second bone in our carpal, or proximal row of the carpal bones, the lunate, it disappears under our fingertips. This is our most commonly subluxated carpal bone. Scaphoid is the most commonly fractured. The lunate is the most commonly subluxated. Okay. If you move your fingers over here to the side of your wrist, you notice that you have some lines there. Those lines that you have there correspond with something called the triquetrum. So we're going to try to chop. Okay, trying to chop. The triquetrum is found right where those little folds are. Those folds you have on your hands correspond to the location of the deep anatomy below it and the folds that have to do with it. So this is our triquetrum. If you move your hand over here on the anterior surface right there, you're going to feel a little small circular bone called your pisiform. Okay? If you put your fingers on it, you can move it around a little bit. The pisiform is actually formed inside your flexor carpi ulnaris muscle. Now this isn't a muscles class, but we want to know that. Okay? The pisiform is formed, or rather located inside the flexor carpi. It's my carpals that are flexing. Ulnaris is on my ulnar side. Does that make sense? So flexor carpi ulnaris. Now those are the 4 bones in our proximal row of carpal bones. Okay? So in order to remember that, we use little mnemonics. You can use whatever you want to. The one that always sticks out for me is some, lovers, try, to chop, positions. Okay? That's our proximal row of carpal bones. What we're going to do now is go down to the thumb again, where we saw that anatomical snuff box. And we're just going to move distal like we're going to the first metacarpal, which is this long bone right here in the thumb. And right underneath it, directly underneath it, is this bone here, the trapezium. So we have scaphoid, and then just slightly distal to it is the trapezium. The trapezium is on the thumb, is number 1. It's the first digit, right? So the trapezium's there. Now, you'll notice with all these bones, if you put your fingers on either side of them, you can move them. These are gliding joints. They're synovial joints. They're diaphragmal joints, okay? Except for one, okay? We'll talk about that saddle joint. As you move over to here, at your pointer finger, right across from where you saw the trapezium, you're going to find a bone called your trapezoid. Okay? The trapezoid is a little bitty bone, and it's trapped between the trapezium and the capitate. How can you find the capitate? Okay? Give yourself the finger. Follow the tendon. That tendon is directly in line with the capitate and the lunate. So if you follow that tendon right through there, all the way down past the metacarpal, just below it, that's where our capitate is. Okay? So again, it's nice and easy to find. You just give yourself the finger, and then you can find it. Okay, it's right underneath that tendon. Now the last one is this big guy called the hamate. The hamate articulates with our fourth and our fifth metacarpal. Okay, fourth and fifth metacarpal. So it's a really big bone, and it has a big hook on it. We call it the hook of the hamate. So on one side you're touching the hook of the hamate. On the other side you're touching the hamate itself, which articulates with the fourth and the fifth metacarpal. Okay. So as we finish our little device, and again, if you don't like this, you can use something else. I just find stuff that's a little vulgar tends to stick with you a little bit more. The scaffolding, we start there, some, and then lovers, try, positions, back, they, can't, handle. Okay? Again, if you don't like that, find something else. There's plenty of other ones. Okay? But that one just always stuck with me. It was easy to remember. How many carpal bones are in the proximal row of carpal bones? 4. How many are in the distal?
3.
4 in the distal. But despite the fact that there's 4 in this proximal row of the carpal bones, only the scaphoid and the lunate articulate with one of the forearm bones, and specifically it's our radius. The pisiform and the triquetrum are actually separated by this structure called the triangular fiber cartilage. If you run your fingers down your ulna, you're going to come to a pointy tip. If you stick your finger in that tip and you chop your hand a little bit, there's a space. In there is a little disc-like structure associated with something known as the triangular fibrocartilage complex. Okay, so we just call it the TFCC. This is another thing that frequently is injured as part of our Fuchs injury, because as the patient falls back and catches themselves, they typically land on this. It also causes dysfunction here, this ulnar mediation, and it damages the tissue inside. Yes, sir?
How do we know the difference when you're like how they do like onto the pisiform?
The ulnar notch to the pisiform. The styloid process. The styloid process is going to feel like the tip of a pencil to you. So if you're feeling like right here, it's going to feel a little bit pointy. And I like to think of it as I can take this bone, dip it in ink, and I can write with it. So you can write the bone with your hands by using the styloid process. The pisiform is going to be on the anterior surface or the palmar surface of your hand. And if you flex through here, you might even be able to see the tendon of the flexor carpioulnaris. If you follow that down into the hypothenar muscle group, you can grab it, you can move it around. The styloid process isn't going to move around because it's a fixed point on the ulna. But the pisiform, if you relax your hand, you'll actually feel it moving around. So let's just take a minute or two and have you find those bones either on yourself. If you've got a friend who wouldn't mind letting you palpate those wrist bones, then you can do that. If you're not comfortable with that, you can just find your own. Let's take a few minutes and try to identify those bones on yourself. As you're going through, part of our criteria when we adjust these bones down the road literally is just do they move. So you're sort of going to be adjusting your own wrist if it were to need it. Okay, so as you're moving, you're on the anterior and posterior aspect of it, and you're going to do what's called a shear force, where you're moving it A to P. You may feel some clicking. You may feel some things slide into place. That's totally normal. Okay, you may not feel anything, but you should feel some movement. Okay, and again, if you have a friend who will let you, then do that. If you don't, that's okay too. You can use yourself. This is your guide, so you can see those. If you need help moving your hands, I'll help you. If you want to feel them, I'll come by and I'll show it to you. If you came in a little late, there's quickly for you. You can still get on that for your attendant. Does anybody need help finding those bones in the particle? Yeah.
The other part popping out. Probably from the top. No, that's high. If you did that whole thing, if you did that whole thing, no, it's what it did.
Like spines. What do you want? They failed the first time, so.
Do you want to know what you're adjusting? Yeah, probably you want to know what you're adjusting, right? And then you also want to be able to pick out if there's a bone that's wrong or something's wrong with one of those bones. How are you going to see the bones though? On an x-ray. So we're going to have to get good at being able to palpate them so that we can assess those bones and adjust them. You're also going to have to be good at identifying those on an x-ray. Can you take extremity x-rays in your office? Yeah, absolutely, right? Yeah, you can definitely do that. Now, as we move distal to these joints that we see here, the carpals, again, I want to point out like how low these are. When I first started coming to the program, I thought like all the wrist bones were like down here, okay, like in the actual palm of the hand, but they're not. They're like down here, okay. So like my 2 row of carpal bones are like between here and here. So they're very low. It's kind of like where you're watching. You're watching maybe just a little low on your wrist. And you need to know where that's at, especially if you're going to do any taping or you're going to do any bracing in your office, because you need to know what you're reinforcing or what you're supporting. Now, each one of these structures, each one of these bones through here, they all have ligaments. Let's see if I have a good picture. You see these guys right through here? Every one of these guys have ligaments that are helping to hold it together so that it doesn't move more than it should move. You don't need to know the name of all those ligaments, but I'll tell you that they're named just according to the structures they connect. So the ligament that connects your scaphoid to your lunate is the scapholunate ligament. Does that make sense? So again, the ligaments are just named according to the different bones that they attach together. That's it. It's nice and simple. Nice and easy. There are some other ligaments that we saw on our list that we will talk about, but those we don't necessarily need to know individually. Now, inside that space between the ulna and in the space where we see the triquetrum and the pisiform, this is where we find that triangular fiber cartilage complex that's being reinforced with this medial collateral ligament of the wrist and the hand. So you see that guy right through there, the ulnar collateral ligament. This is also known as the medial collateral ligament of the wrist and hand. And inside that space is going to be the triangular fiber cartilage. So the only possible carpal bones that articulate with another bone, like in the forearm, is going to be the scaphoid and the lunate. Remember, your triquetrum and your pisiform do not articulate with the ulna. Instead, they articulate with this triangular fiber cartilage complex. We said that that was most commonly injured in what kind of a situation? The pooch. Pooch. F-O-O-S-H. Pooch. Falling on outstretched hand. Okay? Anybody here do like some jiu-jitsu classes and stuff like that, or judo? What do they spend your time doing when you start the class?
When you fall, you
Break fall. Yeah, you break fall, right? You start off by smacking the mat and learning how to fall down. Because if you don't know how to fall when you're in one of those classes, you definitely are falling, right? Someone's definitely going to throw you. Someone's definitely going to sweep your leg. Someone's definitely going to knock you on the ground. You have to know how to fall, or you'll either fracture your scaphoid or you'll tear this tissue. Now, if that tissue tears, it's ligamentous, right? It's not muscular, it's ligamentous. How long is it going to take to get better? A long time. It could be somewhere 3 to 6 months, depending on how the patient stabilizes and supports it, and then how much they're using it, right? When I was younger, I was playing like football somewhere, and I jumped up to grab a catch, caught it, came down, hit the concrete, and completely destroyed this for maybe 2 years. Why did it take me so long to heal? Because I'm an idiot.
Yeah.
Okay? I kept going to the gym, I kept benching, I kept pressing, I kept doing everything with my hand. I would just take it up and I would wrap it up and just make do with whatever I had. And that was really stupid. Okay? But I didn't really know any better at the time. So again, depending on the patient that you're working with, it could take a long time because if they're in the middle of a season or something like that, they might still, like they're an offensive lineman, they've got to keep doing that. And they're afraid they'll lose like a football scholarship or maybe going to the NFL. They're going to keep doing it. So you just got to learn how to support those people the best they can. And don't judge me because you're just as bad. Okay? At least I will. Yeah. So it'll still heal if they provide the appropriate support and stability. It'll just heal slower. I don't know if I would say it would necessarily feel bad. I would say that if they keep doing whatever causes them to get in that position, like if it's a chronic type injury and they keep doing that, that's just going to make it worse altogether until eventually they won't be able to do it. So again, like in some cases, you don't have a choice but to stop. But that's more like a chronic injury where someone's doing that versus an acute injury where someone falls on the outstretched hand. remember, acute means that it just happened like right now. It's just now. If it's chronic from someone doing stuff like typing, their hands are always like this, that normally won't cause a food type injury. It normally will lead to irritation of the muscle tissue, maybe inflammation of the nerves that are passing underneath there, but it won't actually typically damage the ligaments. You could end up with some maybe laxity or something like that in the ligaments. Yeah, if they have the Fuchs injury, it's possible it can still heal appropriately as long as they take rest and do whatever they're doing. So maybe you don't have a choice but to go to work, or maybe you don't have a choice to do that. You would want to wrap it, stabilize it, do maybe 20 or 30 minutes of work, and try to stop or something like that. And it's still going to be very painful and probably uncomfortable, but that is going to extend the lead time and injuries after. That's the biggest thing to explain to your patients. Like when you get a patient in your office who has an injury that could be resolved like today, but they keep doing the same thing, they're not stopping, they're not taking any time to heal. You don't like tell them you don't want to take care of them, you just let them know, listen, I can still take care of you, Mr. Smith, but this is going to take a lot longer because you're continuing any activities that are causing the injury. So I just want you to have the right mindset. If you want the fastest results, I need you to stop this, we need to do these interventions, and then you'll probably be fine by next week. If you're going to continue doing these same things, I think we can still get you where you need to be, but it may take about a month, it could take 2 months. So it just kind of depends on how you want to commit to your care and therapy. Does that make sense? So really just like managing your patient expectation is really the key there, and knowing that it's going to change things. Now the intracarpal articulations, meaning between carpal bones, in between each carpal bone, is a gliding joint. When you feel those bones, if you were to take a friend and like grab the capitate and the trapezoid and you were to apply that shearing force, you should feel them moving opposite of each other in a nice gliding motion. Now, the pisiform articulates with the anterior surface of our triquetral. And remember, it's found inside the tendon of the flexor carpi ulnaris muscle. But the rest of the proximal row of carpal bones are articulating with the distal row. So the only one that's actually articulating with the proximal row itself is the pisiform. All the other ones are articulating distally with that second row of carpal bones. The distal row of our carpal bones are then going to articulate with our metacarpals. The metacarpals are these long bones that we first find here. Okay? We just number them according to how we find them. So it's just the first, the second, the third, the fourth, and then the fifth metacarpal. Okay? That's what's articulating with that distal row of carpal bones. Each one of those articulations is a synovial joint, okay, allowing for a lot of motion to happen. There's ligaments that we have here down at the wrist and hand. The proximal row of those carpals and the distal end of the radius are surrounded by something known as this palmar carpal ligament. Distal to the palmar carpal ligament is the flexor retinaculum, and we want to be able to tell the difference between the location of those two. The flexor retinaculum is going to be in between where I flex my thumb and my pinky. So if you take your thumb and your pinky and you flex it together, you see this fold right through there? This is the location of that flexor retinaculum. Now the reason why I want you to be able to find that is because this is the location of our carpal tunnel, meaning that the flexor muscles of my digits, they all pass underneath this ligament, but also my median nerve passes through this ligament as well too. So it goes through the carpal tunnel, and that tunnel is created by the flexor retinaculum. So again, the flexor retinaculum is here. The palmar carpal ligament, where are our carpal bones? They're down here, right? It's on the palmar side, meaning it's ventral. Another word you can see to describe that is volar. V-O-L-A-R. You may see it written that way. The volar or palmar carpal ligament is down here. Okay? So the volar carpal ligament is down here. Which one did we say was right here? This is the flexor retinaculum. Now, we want to know the difference between those because when we get to our clinical skill classes and we're doing our orthopedic testing, because this is where we'll assess the median nerve, okay, not down this. Does that make sense? So again, in between our thumb and our pinky. Now, why am I spending so much time on this? Because people frequently confuse those. Because on the back of your wrist, in the same location, is the extensor retinaculum. And it's really confusing because the extensor retinaculum is sort of continuous with the palmar carpal ligament. And so people will instead call that the flexor retinaculum. The extensor retinaculum gets its name because it's holding down the extensor tendons down here. The flexor retinaculum is getting its name because it's at the union of where these flexor muscles are in the median. Are we okay with the difference between the two? Palmar or volar carpal ligament is down here. Okay. Flexor retinaculum is between these two guys. Yes, sir?
So flexor retinaculum is slightly more distal and it's also deeper.
I would say, yeah, slightly deeper. Yeah. The extensor and palmar ligament there are very, very superficial. Most of the time, you don't even see them when you look at a bone model because they're so superficial. They're holding down tendons and muscles and structures like that. So you won't even see them when you're looking at the bone models. Instead, you'll just see the flexor retinaculum.
How often do those get injured?
I don't know that I would say that the flexor retinaculum gets injured, but if you were to think about it, let's see if I've got a picture of it. Passing underneath this small space, right through here, this little bitty space underneath there, is going to be all the tendons that go down and move all your digits. So these guys right through here are moved by something called the flexor the flexor digitorum superficialis and the flexor digitorum profundus. All of those tendons, all 8 of them, are passing underneath this thing called the flexor retinaculum. It's very small. The median nerve is located anterior medial in the carpal tunnel, and it's passing through there as well too. So if you're doing something like typing all day long, you're using these flexors all day long, right? Those tendons and muscles become inflamed, and then that compromises the space of the actual tunnel itself, and then it squishes everything together. So I don't know that I would say the flexor retinaculum itself is getting injured. It's just that because it's a small tunnel, if this tissue gets inflamed, it presses the nerve against the ligament, and then people end up with what we call carpal tunnel syndrome. So I wouldn't say that the tissue's damaged itself, but just that the space is kind of compromised. And this nerve we see right through here, this is the median nerve. So a patient comes into your office, and they tell you they have pain in their hand and digits. Depending on what kind of office you are, you might say, okay, let's have like carpal tunnel syndrome, let's get you this therapy, and this therapy, and you'll be fine. If you came into your office, you're going to go back and do a physical exam on this patient. Okay, so Mrs. Smith, I understand you're having some pain in your hand. Can you point to where you feel that pain in your hand? And Mrs. Smith points over here at her pinky. Is this where the median nerve is? It's by your what? Your thumb. And it goes into these digits. So I immediately know she does not have what? She doesn't have carpal tunnel syndrome. So if someone else has been treating her for that, they've been treating the wrong situation. Does that make sense? Our ulnar nerve, not surprisingly, is on the ulnar side. Does that make sense? So remember, the ulna is on the pinky side. The ulnar nerve supplies this part. Okay? So if the patient comes in and they point here, I immediately know they've got the wrong diagnosis right off the bat. Okay? The median nerve is going to have pain and discomfort on the thumb, pointer finger, second finger, and I know it's a little confusing if you think in anatomical position. It's also going to have pain and discomfort on the lateral half of the ring finger. So the lateral half of the ring finger and these first 3 digits all get sensory innervation on the palmar side from the median nerve. Okay? Now that's an easy way just to tell whether or not they have median nerve compression or they have ulnar nerve compression as well. But we'll talk more about that as you get to gross 2 about how to identify those. Are you okay with where the structures are? The palmar carpal ligament versus the flexor retinaculum? Are we okay with the difference between those 2 tissues? Yeah. Remember, flexor's down here. Okay? Flexor's down here. Palmar's down here. These are pretty easy. On the palmar and dorsal side, there's the metacarpal ligament that holds the metacarpals together. We'll take a look at a picture of that in a second. And then we get down to our phalanges. Okay? The phalanges themselves, we have 1, 2, 3, 4, 5. Phalanges 2, 3, 4, and 5 are made up of a proximal, middle, and a distal phalanx. So these singular phalanx. So it's made up of a proximal, a middle, and a distal phalanx. Your thumb is only made up of 2 of these. It's made up of a proximal phalanx and then a distal phalanx. Okay? So the thumb only has 2 of those bones, the digits 2 through 5 have 4. That means that the thumb is not going to have as many joints, right? Because it doesn't have as many articulating bones. The thumb instead only has this one guy right through here. It's called an inter. Remember, inter means between two things, right? Interphalangeal joint. It's the joint between our thumb and the proximal phalanx. Excuse me, the distal phalanx and the proximal phalanx. Okay. Are we okay with that? So this joint you have right through here is interphalangeal joint. As you move down to your pointer finger, between the proximal and the distal phalanx, there's a joint on both ends here. So we have a joint here, and we have a joint here. There's still interphalangeal joints, but now we need to differentiate between the two. We do that by saying proximal and distal. So this would be our proximal interphalangeal joint. This will be our distal interphalangeal joint. The joint of your knuckles right through here, this is the metacarpal phalangeal joint. It's just named based on the two things that it connects. Metacarpal to the phalange. Metacarpal phalangeal joint. Proximal interphalangeal joint. Distal interphalangeal joint. Okay. 2 through 5 have proximal and distal. The thumb only has the interphalangeal joint. You okay with that? Let's take a break there. Let's come back in about 5 minutes. Okay, and then we're going to move into the lower extremity. I hope the review of the first half of the material kind of helps refresh your mind. I know it's been a couple weeks. Here's your quickly if you guys still want to get on that or you haven't gotten on that yet.
So really on that, it's really carpal bones that not really palpate.
No, you should be able to palpate them all. Even if it's like a big power lifter, like if their hands are like ginormous, you still should be able to get in there. You should still be able to palpate and feel those things moving. They may not move a lot because power lifters typically don't have a lot of range of motion because they're creating more stability so they can do the heavy throws. So motion may be really small, but you still should be able to find it. Okay. And then I'll give it to you. Is that okay?
No, I don't want to try it because if I tried it somewhere, I can bet what you're sporting.
I may not. I haven't done it in the past. People have done it pretty well. Yes, I normally only do it in my classes. Really, it's knowledge. They aren't currently. Knowledge sector is interesting. We haven't done that. So we're probably I normally I feel your pain, man. I feel the same way last week. I feel like I said this week on Wednesday, so missing Wednesday. So I get that chance. See if you're running into any issues over this message.
There we go.
Yeah, look back and see like
And my phone.
Why is that phone like that? I didn't not say anything.
They're a little yeah.
No, but it's easy to get.
Is it? No, it's not a t-shirt.
Just wanted to check it out. Yeah, what's that?
Oh yeah.
I'm playing on that game. Pretty much starting from the ground.
It's all good. Yeah, feel free to I try my best.
I mean, it's better than one I've got.
I also, what I usually do is I'll keep power
No, me either. I think he's well, that's not because I'm bragging on myself. Wisdom skills. We should do this. I've got her wisdom now. Yeah, we can use her for.
I think sometimes it's probably just stuff like I.
Oh yeah, there's just like measures.
All right, guys, let's go ahead. Let's come back together. All right, we're going to be moving into the week 8 lower extremity. If you look in your week 6, you're going to see that there's something about bone growth and development. We'll be coming back to that, okay? But we're not going to do that today. We're going to keep moving to this quarter. I want to clarify something in your grade book. Just because I've gotten a couple questions, I didn't realize you could see it this way. Your practice test had no point value, but it shows a point value. I left the point value up so that you could see like how you would perform at that end of the test. Does that make sense? but it has zero impact on your grades. Okay? If it's set up in grade book where it looks like you're missing those points, or if you just took the practice test, copied and pasted the answers, and created a Quizlet or something like that, I don't care, that's fine. And if you made a 0 on that test, it doesn't impact your final grade. So if you're looking at the grade book and you're like, oh, wow, I made like a 10, I didn't realize it was an impact on score, it's not. Okay? I'll correct that. I'll try to correct it today in the grade book so that it doesn't look like that. I only left the score up so that you can see if this was a test, how would you have performed on that test. Does that make sense? Yeah, so I'll try to rearrange that today so that we don't have that. Yes?
When are we, I know you won't tell us necessarily, but like, we're supposed to have multiple quizzes in this.
Yeah, we are supposed to. I don't think that I have time to do one today. I wanted to do one today. I think what I'm going to do is I'm going to open it up and just let you take it over the next week. Yeah, I think I'll just open it up. So look on Blackboard today or tomorrow for it to say something like a knowledge check has been released. The knowledge check is technically like the quizzes that are supposed to be taken inside the class, but just because of missing last week, I don't think that we have time to do it inside the class. So I'll open it up. It does have a point value. It's like 1% of your overall grade, so it's not a significant portion, but it is 1% of your grade. So you'll have 7 days to complete it as opposed to just doing it in the class. I also will leave that after the due date closes. I'll leave it open access so you can go back. Initially, you won't be able to see your answers. Okay, so you'll complete the quiz. You'll see your score. That'll be it. You won't see what the questions were. You won't see what your answers were. After the due date is done, I'll go back in and I'll open it up so you will be able to see that. And you can use that to study for your final. Okay, it'll help you study. Yes?
Can you also open up the practice test, or is that still open?
I could open up the practice test, yeah, because some of the final will be cumulative. So we could open that up as well, too.
Thank you.
And thank you guys for your patience, because I know some of you guys have emailed me, and I've missed your emails, and then you email me again. Thank you for doing that. If you don't hear back from me within 24 hours or 48 hours, there's a good chance that your email got buried. Just email me again, and I'll respond to you. Yes?
Are you planning on having the same practice exam structure for the final?
We probably won't do a practice exam for the final. Really, the reason I do the practice exam is to determine so you've never taken me before, and you need to know what kinds of questions are going to show up on your test. But between the practice test for the midterm and the knowledge check, you should have a very good idea of the type of stuff I'm going to ask you for on your final exam. But normally that's so. Any other questions? Yes.
For clarification, I would only have one quiz.
I think so.
Yeah.
Yeah, I believe it is. Yeah. I hate those things. You know what they are? We were told we could no longer hold you accountable for coming to class at one point. And everyone was in uproar. And they're like, so what? How can we hold them accountable? Because if you're not held accountable, we can do it. I hate to say it, but you won't. Normally, if people aren't held accountable, if there's no measure of you doing stuff, most people won't show up. So all the teachers were like, well, we could do these things that are knowledge checks, in-class participation points, and you have to be there in order to do it, so now students have incentive to come. And so the entire reason they were put into the class was for that reason. I hate it. I can't stand it. So I almost rather just hook them all up and do whatever you want to. But if I did, I'd be like rebelling against all the other teachers, and they might come back to pitchforks, torches, and stuff like that. I don't know. It could be bad. I've had a few like disagreements with other professors at events and stuff like that. Where eventually I just had to look at them and like, do what you want to do in your class. I got mine. I'll see you later. And I'm out. But yeah, so I think we've only done maybe one. And we did the practice test, which has been good. Okay, organization of our lower extremity. When we talk about the hip, we're really talking about the gluteal region. And if a patient comes into your office and they're saying they're having some glute pain, I would encourage you to ask them that first question of like, Mrs. Smith, I understand you're having some issues here in the glutes. Can you feel that pain? They may point to like right here at the femoral acetabular joint. They may point back here to their SI joint.
Yeah, I did.
They may point here to their actual glutes. And it could be any of those three. Each one of those is going to have a different sort of thought process into what's happening, right? If it's their SI joint, well, then I'm thinking maybe it's SI joint dysfunction, like their sacroiliitis or something like that. If it's literally right here in the femoral acetabular joint, there could be a labral tear. If it's in the gluteal region, it really could just be a muscular issue, and it just needs to be worked out, or it could be piriformis syndrome. So again, we always want to ask the patient to clarify, what do you mean by glute
pain. Does that make sense? It can be helpful sometimes to have like the little pictures on your health information intake forms so that they can draw where their pain is, and that sometimes will add clarification in there as well too. Your thigh is all this stuff here. It's not your leg, it's your thigh. And I've always thought of this entire thing as my leg, but it's not. This is your thigh, this is your leg. Your leg is really your tibia and your fibula. So again, the leg is from knee down to the ankle joint, and then the foot, of course, typically includes portions of the foot and some of the overlap between the ankle bones that we see as well too. Your pelvis is made of these 4 bones technically, but really it's just 3 bones. So the ilium itself is made of the ilium bone, the ischium, and the pubic bone, and we're going to see those sort of color-coded for us so we can see that. The sacrum technically is normally made between 3 to 5 vertebral segments that are fused together. So your sacrum is normally 3 to 5 fused vertebral segments. When you're taking care of pediatric patients, so they may not have fused at that point yet, depending on how young they are. So you actually sometimes will be adjusting a pediatric patient's sacrum, and you will feel an individual segment. Like you'll feel S2 move, or you'll feel S3, S2 move, instead of the entire sacrum. So again, our pediatric patients, as they're developing, this is not completely fused sometimes, and you'll feel individual motions happening. The pelvis itself is meant to support the weight of the upper body and sort of transmit that force down to our femoral acetabular joint around the greater trochanter area. Typically, as we move, in linear moving straight, we're transmitting a rotational motion of the spine through the sacrum into the lower extremity. Now, the pelvis also is going to protect our organs. For females, it's the reproductive organs. For the uterus, for the male, it's really just the bladder that's in there and the distal colon. And then this is also our attachment side for our lower limbs via the acetabular joint. The acetabulum itself is 1, 2, 3 bones fused together. Now, when we're developing, and again, if you're looking at a pediatric patient, you may see that these 3 bones have not fused completely together. Now, technically, they are together. It's just that it's cartilaginous connections. It's not bony connections. Because remember, we start off with sort of a cartilaginous mold that slowly gets replaced by bone as we go through our life. So these 3 bones, as we look at a pediatric x-ray, will be completely separate, or at least look that way. The ilium, that's the portion up here. We can put our hands on our hips, right? That's our ilium. That's our sassy bone, right? Like, what did you say to me? Okay, so that's our sassy bone. The pubic bone, that's our, I don't know, you can go something there. The ischium, this is the one that we sit on. So the ischium, if you reach back and you feel the bumps that you're sitting on, that's your ischial tuberosity. So those 3 bones all join together. Where they all meet together is the acetabulum. Okay? The acetabulum is the union of where we see all 3 of these bones meet together, and it's this space right through here known as the acetabulum. You see the line kind of separating out the 3 bones? It's the acetabulum. Now, there's some good landmarks on our ilium that we use. And in order to find them, we have to understand the difference between the pelvis that we're actually palpating. If you're palpating the male pelvis, typically the hips are kind of high. My hips are up here, and they normally are more narrow than our female counterpart. Those are typically going to be more like belt level. So normally, in order to palpate the female pelvis, we have to roll down the shorts maybe just one time, or the pants, in order to get to the other structures that we're going to try to palpate. So again, male pelvis is way up here. Okay, way up here. Female pelvis is typically down here, kind of where my belt line is. Now, there's some really good landmarks that we have right here. You see that big bump right through there? You see this big bump right through here? These 2 big bumps right through there, they tell me that this is the anterior part of the pelvis, or the ilium. And then this big notch back here, this tells me that this is the posterior portion. When we get to our lab test in 4th quarter, there'll be a bone laying there on the table, like an ilium bone, and there'll be a dot on it. And just by knowing the difference between the front of the pelvis and the back of the pelvis, you can get those questions right. Like, one will be our anterior, superior iliac spine. Remember, spine's kind of like a pointy part of a bone. And then the other one on the back side here will be our posterior superior iliac spine. And just by knowing the difference between posterior and anterior, you can get that question right. The internal surface is going to have this thing known as the iliac fossa. We're also going to see part of the superior pubic rami.
The lateral part of the bone is really easy to identify because it's where we're going to find the acetabulum. You need to be able to look at that bone and know immediately this is anterior, this is posterior, this is medial, this is lateral. Does that make sense? And you need to be able to identify the different structures that are associated there. Now, anteriorly, we have an AIS, and then we have an AIIS. So anterior superior iliac spine, anterior inferior iliac spine. On the back side, we have our PSIS, or posterior superior iliac spine. If you palpate your iliac crest and you go all the way back to here, you're going to feel a little point or a little bump. If you take your body and you stand up, you can pick your knee up, and as you do that, you're going to feel that PSIS kind of rock back. Okay? So as we move into flexion of the hip, it causes posterior inferior movement of the ilium, or at least it should. When we get to our motion palpation classes, we're going to put one finger on the PSIS. We're going to put another finger or thumb on the sacral tuberosity or the S2 spinous process, and then we'll have them flex their knee. And if we don't feel that motion happen, where the PSIS rocks back and the sacral kind of rocks anterior, what do I know is happening? It's fixated. I can't say it's subluxated yet. Remember, in order to classify something as subluxated, it's going to have more than just the one motion criteria. There's also going to have to be a disturbance in how the muscles are moving or how the joints are moving. But there also has to be pain, there's tenderness, there's edema and swelling in that area. There's also typically some sort of neurological dysfunction that's happening as well, too. We need all of those different things together to say, no, this is really subluxated, and we really need to adjust that as the primary point of that subluxation. PSIS, and then there's also a PIIS, posterior inferior iliac spine. So you have a PSIS and you have a PIIS. You will use your fingers on both of those structures in order to be able to flex the patient's knee or have them flex it, and you'll use that as part of your assessment for whether or not there's sacral fixation, possibly a subluxation of that area. Now, in order to get to it, what are you going to have to do? Where's my PSIS? My PSIS is like right here, just above my belt line. Okay? What did we say you have to do to find that for a female? Maybe roll the pants down just a little bit, and by rolling one time, you should be able to get to the PSIS and the PIIS. So ladies, it's not like your pants have to be taken off or something like that. Okay, literally it's just like one rolls down, and then it's right there, and you'll easily be able to palpate those structures. Okay? Now there's other things that are important to know in here, like these gluteal lines correspond to the origin of our glute max, medius, and minimus muscles. The acetabular joint is broken up into different sections. We'll talk about that as we talk about the femoral acetabular joint. The pubic bone is going to be broken up into a superior pubic rami and an inferior pubic rami. Do you remember what a ramus is? A ramus is just a handle-like structure, right? You remember the mandible, the ramus of the mandible? The ramus of the mandible looks like you could grab it, right? And you could like hit somebody with it for fun. Okay? The superior pubic rami is the same thing. It looks like something you can handle or like grab like a bicycle handle or something like that. It's the same thing with the inferior pubic rami as well. Okay? We okay with that? Now, how low is the pubic bone really? Right about here. And if you're palpating the pubic bone, you want to be really careful, right? Because what's directly attached to our pubic bone? If you're female, immediately inferior to that is the clitoris. It's actually anchored partially to that pubic symphysis. And so typically if we're palpating that area, we just ask our patients, can I just have you do this for me? And they just cover over the genital area, and it's no big deal. You don't have to say, hey, could you protect your vagina? That doesn't sound good, does it? That sounds really bad. That sounds like I might be getting a call later from like a lawyer. Bad. But you instead could just say, hey, can I just have you do this for me? They just cover over the area, and now we can palpate. You're going to need to palpate those types of areas if you're especially if you're taking care of pregnant women. A lot of times the round ligament passes right over the top of that pubic bone and becomes tense and tight, and it can be really painful and uncomfortable, so you'll need to know how to trigger point that and release that muscle, and it's very close. Okay? So we want to communicate clearly with our patients that I'm going to be touching this bone. If you have a model in your office, that's fantastic. You can pull it out and show specifically where you're at and explain why you're doing it, and then you clear up any kind of confusion, okay? Same thing for men. Technically, there's a ligament that's connected to the dorsum of the penis that anchors from the pubic symphysis as well too. So it's right in that area of the genitals. Again, whether you're palpating a male or a female, we still just say, hey, can I just have you do this for me?
They cover over the genitals. No big deal. It doesn't matter. They're not really surprised you're doing it as long as you're clear with what you're doing. The ischial tuberosity, we said that's going to be where you do what? That's the bone that you sit on. We're going to learn that there's some ligaments connected from the ischial tuberosity to the sacrum. It's just known as the sacrotuberous ligament. And there's also another one called the sacrospinous ligament. Those ligaments help hold our pelvis together. And as you sit down, the pelvis kind of opens up a little bit. Now, the sacrospinous ligament is doing what it's supposed to. It's attached from the spine of the pelvis over to the sacrum, and it keeps the pelvis from opening too far. So if a patient tells you they're having pain kind of in this area when they sit down, I know there's probably an association with their sacrospinous ligament. Does that make sense? So again, we're going to use these landmarks to help us understand and evaluate our patient's skill to identify pathologies that are associated with it. Now, I'm not going to read off all these different anatomical portions on the ilium and the pelvis. This is part of what the project was for. We'll talk about some other stuff associated with this as well, too. We have an anterior SI joint, and of course we have a posterior SI joint. The anterior SI joint is partially synovial, it's partially fibrous, and we'll talk about that as we get to the joint portion. But it creates this continuous ring, including the sacrum, with the base of the sacrum around with the pelvic bones, what we call the pelvic inlet. The pelvic inlet, if you were to think about it, is like going inside the pelvis, where for the female we find the uterus, bladder, and then of course the rectum, and for the male we just find the bladder in that area, and of course the rectum as well too. So the pelvic inlet is going inside. The pelvic outlet is like looking, I don't know, like if I had a quilt on and you wanted to look at my quilt, you're sick and twisted. Okay, that's the pelvic outlet that you'd be looking at. Okay, so the pelvic outlet is going up, the pelvic inlet is going into the pelvis. And if you look right through here, we can see this thing called the subpubic angle. The subpubic angle is a great place to look for gender. Okay, so if you're looking at a cadaver or you're looking at a skeleton, if you want to know am I looking at a male or a female pelvis, we just look at the subpubic angle. If it's 90 degrees or less, then we would know that it's a male. If it's 90 degrees or more, then we would know that it's obtuse or that it's a female patient. Okay, so again, bigger than 90 degrees would be female, less than that, it's male. There's a TV show called Bones. You guys ever seen Bones? The forensic anthropologist. There's one guy who's got the top half of the body, and he's trying to do his forensic report. The other one has the bottom half of the body, and she's trying to do her forensic report, and then they're arguing with each other about whether it's a male or it's a female. Okay? Because he's got the upper half, and the cadaver has breast. She's got the lower half, and she's looking at the subpubic angle, and it's less than 90 degrees. It's male, right? And they're arguing with each other until she points that out, and he's like, oh. So again, by looking at that angle, you can know like at least what they were born with anatomically, maybe not what they identify as. Okay? So again, this doesn't really lie about that portion. All the other stuff, all the other anatomy can be changed. That can't be changed. If we look at this pelvic or pelvis right through here, is this male or is this female? It's male because it's less than 90 degrees right here at the subpubic angle. Our pelvic inlet is created by anteriorly the pubic symphysis, or rather the boundaries for the pelvic inlet are created by the pubic symphysis. The sacral promontory, which is the most prominent anterior portion of our sacrum at the base of the sacrum. And then the ala. Ala means wing-like. The ala of the ilium are these wing-like structures through here, and that's what creates the lateral border of this guy. Now, we're going to learn that this is also known as the iliopectineal line, okay, as we get into the joints. Or rather, I guess we'll learn it right now. This is the pelvic outlet. I'm not going to read all this to you, but you need to know the difference between what makes up the boundaries of the pelvic inlet versus what's making up the boundaries of the pelvic outlet. We okay with that? Acetabulum. Acetabulum has several parts associated with it. If you look here, it looks a little bit like a crescent moon. Okay, so this is the lunar or lunate surface. The acetabular fossa is the deep depression that we find in between where we find that shape. Acetabular notch is a space in between the rim of the acetabulum. Now, the acetabulum itself doesn't sit in the body like the glenoid cavity. Remember the glenoid cavity, it just sets off to the side sort of like this. The acetabulum doesn't do that. It has an angle that's associated with it. It also has a labrum that wraps around it. If we want to know if a patient has something like a labral tear, we can typically take their knee and their thigh bone and we can move it into internal and external rotation. As you're doing that, the femoral head will rub against the labrum and that internal and that external rotation. So we'll talk about that later in your extremity classes as being an impingement syndrome for the femoral acetabular joint. And then we'll talk about the different classifications of pincer versus hand deformity. Yes, sir?
What if you can do one and not the other? Let's just say you can do internal, but you can't do external.
So
Is that a muscle problem, or is that still probably a labor?
So it's still, if it's still from the AB or adduction, the internal and external rotation, it's still likely associated with the labor. If the patient is doing this, and this is where their pain is, this is the line of connection from our psoas and our iliacus muscle that connects into the lesser trochanter. That flexion motion, sometimes you get a popping sensation. Anybody here get a popping sensation? That typically is your iliopsoas muscle gliding over the lesser trochanter, creating that popping sound, which normally is a tension or a tightness in the muscle itself that needs to be stretched and released normally.
Is the pain usually on the anterior side of the body?
It's sometimes if it's in here, and sometimes it'll be here, and sometimes it'll radiate into the groin area as well. Yeah, so it normally doesn't prefer posterior.
But it won't start in like your glute.
No, normally if it's doing that, it may be in association with the glute medius. The glute medius also inserts around that same area. It's one of the things that stabilizes our pelvis as we move, and that probably is a greater likelihood. Maybe your piriformis as well too would be implicated there. And that's why it's important for you to go in and do the actual palpation and actually feel what the issue is, and then motion it, and then see if you can elicit pain by feeling a specific motion, and then normally that'll let you know that. Palpation associated with motion palpation, that's a pretty good indicator. And then you can let your orthopedic test it. But it doesn't sound like a deal with the issue. If someone has snapping hip syndrome, okay, where they've done like, maybe 1,000 sit-ups, like when I was 12 or 13 years old, I was a big chubby kid, okay, and so I wanted to have rock hard abs. Sometimes I still want that, I can't get them, okay, I pay for them, I can't afford them, okay. So when I was little, I thought if I did like 1,000 sit-ups a day, what would happen? Boom, okay. Instant success overnight. Everyone would love me. My picture would be on the top of the cover of magazines and stuff, right? Of course, that wouldn't happen. But I thought that's what would happen. So I did thousands. You have no idea. Okay, I don't do something halfway. I do it all the way. I don't take a class. I get a PhD. Okay, so I'm really, really motivated. I did thousands of sit-ups every day, and then every time I started lifting my leg up, guess what happened? Snap, flip, pop. I was putting my feet underneath the base of this TV to hold my feet down. When you do that, guess what muscle you activate over your abdominal muscles? Your psoas. And so really, I wasn't even isolating out or really working my abs as much as I thought I was. I mean, I was because I was doing so many sit-ups. So I still would feel the pain in discomfort, but I wasn't aware that doing the flexion of the hip and by having that stabilized, you actually activate that muscle. It normally will only happen on one side though. If your psoas muscle contracts on one side, it's attached to your lumbar spine and your last thoracic vertebra. So guess what it's going to do on that side? It's going to cause a little curvature in that lumbar spine. Guess what your pelvis has to do? It has to compensate. Because am I going to walk through the day like this? Probably not. Instead, my pelvis is going to correct and my thoracic spine is going to correct. And now I have these two compensatory things happening in my spine to compensate for this issue of my lumbar spine. Does that make sense? If I go see my chiropractor, I'm probably going to tell them I have some low back pain and I have maybe some hip pain. And they're going to go in and maybe adjust my SI joint and adjust my lumbar spine. And then next week, what am I going to have? Maybe even later that same day. I'm going to have that same pain. You're going to adjust me again, same pain. Adjust me again, same pain. Adjust me again, same pain. Why? It's not really the subluxation that's the issue there. It's not even really a subluxation because that's not the primary dysfunction. The primary dysfunction is that muscle. Does that make sense? If this muscle on the right side is really tight, everything on this side is being really pulled. Does that make sense? So one side is really tight, other side is really stretched out. If I give my patient a stretching exercise to loosen this up, and I'm not careful, they'll also stretch out this side. This side's already stretched. Do I want them doing that in an already stretched muscle? Hey doc, this feels a lot better. Now I'm having this really intense pain on the other side. You know what happened? You're like, oh shoot, I forgot to tell you, don't do that on the other side. It's already stretched. Instead, on the other side, what might they need to do? Strengthen. What you're going to find sometimes when it comes to an imbalance in the spine is that one side has to specifically have one type of therapy, where the other side has to have a complete opposite. If they do the same therapy on both sides, it'll worsen the problem. Does that make sense? So the tight psoas needs to be released. The stretched and weakened psoas actually needs to be strengthened, or maybe even just left alone. And the balance itself will be restored to the pelvis. Does that make sense? So again, you have to be careful when you explain that to your if you don't explain that to your patients, because they'll do both sides, because you always think you're supposed to do both sides, right? Yes, sir?
So you did all the sit-ups. Why was it only activating your psoas on one side?
I wouldn't say that it was only activating my psoas on one side. I would say that this side was more dysfunctional, and it led to that issue appearing here. It could be because I'm right-handed. It could be because I'm left-handed. It could be because when I step, I always step right, and this side's already under more tension and more stress. Because we don't have perfect symmetry of the body, we don't use right and left equally, and we create sort of an imbalance. That imbalance is really not that big of a deal right off the bat, but once you do something extreme, like 1,000 sit-ups, 2,000 sit-ups, now you're pushing it to the absolute max, and if there's any sort of weakness in there, or if it's already fatigued because you use it so much, it gives out first.
So you're saying that's not unique to the psoas, like that.
Absolutely. Yeah, absolutely. And that's why it's really important if you're taking care of your patients that you assess that musculoskeletal system as well too. You need to assess the muscles that are associated with the tissue. The muscles may be their primary dysfunction. I don't know that we can really call that a subluxation. I sometimes think of this sort of like a muscular issue that's called it a subluxation, but until you address that, it's not going to get any better. Here's that femoral acetabular joint itself. Do you see how deep that is? What kind of joint is that?
Ball and socket.
It's a ball and socket joint, which is also synovial, pneumatic intuition, which is also diarthrotic. We don't see as many dislocations of the femoral acetabular joint as we do our shoulder joint. Our femoral acetabular joint is actually much deeper, and then it also has a labrum to make it even deeper. And then, how many people in here can take their leg and put it up over their head? Anybody in here do that? When I was training karate for a long time, I got a stretching machine, and I did it every single day. And I'd spend a lot of time cranking it out, just like Van Damme back in the 80s. Blood sport, he's like getting racked on this thing. And I was like, I'm getting one of those because I'm sick. I have problems. And eventually I got to a point where I could do that. I could take my leg and it could go all the way up overhead. But one day I was using that machine, and guess what happened? It snapped. I broke it. I broke the machine. I'm so mad. But I couldn't afford to get another one, and I couldn't afford to replace it. What happened after about 2.5, 3 weeks? I lost all of it. I don't know what happened. I lost all of that. So I don't know. I think part of our mobility, maybe if you start young and you train it, or you're naturally gifted towards that, you keep that mobility. But most of us can't do that. So if you can, good for you. That's awesome. Okay. I always thought that was really cool. I don't know why. But I always thought it was really cool. So inherently, we normally don't have that much range of motion in the femoral acetabular joint compared to what we see in the humeral joint. But it also is much deeper in the fossa, where it actually sits in that acetabular fossa. The other thing, too, though, is that sometimes our patients will have problems from the tops, so they have impingement, or they don't have enough range of motion in the femoral acetabular joint. If we were to all, sit down into a full squat from our standing position, how long would we stand there? Or sit there? We all just went down, squatting down, straight down, butt to your ankles, and you're just sitting there. Sort of like you're using a squatty potty. You guys ever seen those? When I was in Singapore, they had those. I had to try it. We're all seeing it. I love it. Okay? But again, that range of motion requires good mobility of your femoral acetabular joint to be able to get all the way down like that. So again, a lot of patients actually experience a decreased range of motion in that femoral acetabular joint, as opposed to up here, it tends to be too much range of motion because of all the mobility we already have and the instability there. We'll talk more about that as we get to the joints. I'm already getting into the joints already. Male versus female, we already talked about that. Remember, your subpubic angle is going to be sort of key for helping us. Earlier I said 90 or above would be female, but it really is classified as 100 or above. Now, in order to see your patient's pelvis, you're going to have to do what? You're going to ask for x-ray. All these landmarks that you've gone through and you've labeled in your osteology project, you're going to have to be able to identify all these from an x-ray, because that's the only real way you're going to see it. Okay? What do we know about an x-ray? What is an x-ray? It's definitely a picture of bones. It's
also just a picture of a moment in time. Does that make sense? If your patient is standing there perfectly the way you place them, you walk away to push the button to take a picture, and they think for a second about how much pain they're in, they may shift everything. And suddenly the picture you're looking at is not really what's happening inside the body. Does that make sense? So again, x-rays themselves are a picture of a moment in time. We need to combine the x-ray with your physical exam, your emotion palpation evaluation, and your static palpation, and then the x-rays in there as well too. Using the x-rays by themselves, I would never use that to adjust the patient just based on those x-rays. Because again, I don't know what was happening, and unless I did the x-rays, I may not even trust that this is an accurate reflection of their spine. If you had something like people moving to forwarding motion while they're doing the x-ray, like fluoroscopy, then you can see them moving in real time, and then you get a better assessment of what's happening. But that's really expensive to get done. This picture in here is not because I'm going to test you on this on your final. It's just to let you know that you are going to have to know all of these landmarks from an x-ray that we're talking about here as well too. Got just a couple more minutes and then we'll be done for today. Our femur and our patella, the thigh bone, articulates with the pelvis, but it also articulates with the tibia distally. Anteriorly, it articulates with the patella. The patella itself is formed inside something called the quadriceps tendon. When we initially are developing, we have these four muscles, quad, four, right? And they go over the knee joint and attach to the tibial tuberosity. But as we're developing, the patella begins to form inside the quadriceps tendon, okay? It's sort of a leverage point to facilitate motion or protect motion through there. So here's our patella. The inferior aspect of the patella is the apex. The base of the patella is at the top. If you look at the anterior surface of the patella, it normally is going to be kind of smooth, but there's going to be some roughened edges associated with it, versus the posterior portion of the patella is going to be completely smooth because it has the facets that articulate with the femur. Does that make sense? So the back of it, if you run your fingers over it, it's very, very smooth. It's like marble smooth on the back side of it. And that's a good thing because you don't want any rough stuff catching on the patella. Proximal femur, easy to identify because it has the femoral head. The femoral head is also pointing medial. Does that make sense? So this is all the medial surface. This is our lateral surface. And it's very easy to identify that. If you look at the anterior surface of the femur, do you see how smooth this is? There's like nothing on it. And then if you look at the posterior surface, do you see this right through here? This is known as the linea aspera. The linea aspera primarily is the connection for our adductor muscles. And of course our adductor muscle is called adduction. But they technically, because they insert here, they not only cause adduction, they technically will also cause extension of the femoral acetabular joint. Because they're inserting back here on the back of the thigh, they don't purely cause adduction, they cause adduction and extension of that femoral acetabular joint. The distal part of the femur, it's also easy to identify because of this soft surface for the patella versus these giant femoral condyles and this intercondylar fossa. Remember, inter means between two things? Intercondylar fossa. So it's in between these two femoral condyles. If you think of the femoral condyles, they look like a bigger version of our occipital condyles, right? It's sort of the same shape. Are we okay with how to tell the difference between the anterior, posterior, medial, lateral surface of the femur? We'll get into some of these different landmarks through there next week. We'll also be going through the joints of the lower extremity. You probably have noticed it's hard for me not to talk about the joints as I'm talking about the bones. So we've already talked about a number of those. So that's how we're going to go through quickly. We likely will get into the growth and development portions of the bone as well too, or the slide that you saw on the top, and then that's week 9. Depending on how far we get, we'll sort of determine how many people can do actual presentations week 10. I know some of you guys want to do presentations, but we're going to get extra points for doing the presentation. In order to do the presentation, you just need to let me know you want to do it. The presentation itself needs to start off with this criteria. You're going to start off by sharing how you did your presentation, how you put it together, how you did your osteology project. What app did you use? Did you print out pictures and then label those? Did you use Notability? Did you use Good Notes or something like that? You'll spend maybe